right, everyone. Welcome to our Monday edition of our Next Gen Nurses free webinar series. My name is Jennifer Bonner. I serve as the tutor team lead here at Arch Review, and I absolutely love what I do. There's nothing like working with students, seeing those aha moments. I just absolutely delight in those daily interactions. So today we're going to talk all things EKGs, whether you love it, you hate it, or you're somewhere in the meh, this is for you. So what we're going to do is we're going to start with that cardiac anatomy, going to break things down a little bit, and then we're going to talk about some of the most common EKGs that we're going to see. So before we get started, tell me, how do you feel about EKGs? How do you feel about the cardiac system? I want to know. If you're following us on TikTok, Instagram, please go ahead, share with your friends, let them know that we are live. We're going to have a great half an hour of learning together. I'm so excited. See people joining from all over the world. So, feeling lovely. 4.5. Okay. Challenging but interesting. That is fair, I think. That checks out. All right, challenge can be complicated, but I like it. Okay. I love EKGs. Okay, that's awesome. It's so funny because you see, there is something in nursing for everyone. For those who like the most difficult concepts, there's something for you. For some that are like, you know what, EKGs are not my cup of tea, but you know what, I'm here for it. Makes more sense as I continue to practice. Absolutely, Shannon. That is great advice. Because, there are times when we really struggle with some of those difficult concepts, but the more we practice, sometimes the more sense it will make. Basic rhythms, yes. Blocks, not the best at identifying. Okay. Very good. Okay. So, wherever you are, if you're kind of like, I need some really big help, or step aside, Jennifer, I got this webinar, we have something for you. We're going to break it all down into bite-sized pieces that you're going to be able to understand. But please remember, we are nurses too. We were in nursing school just like you. We were getting ready to take our NCLEX just like you. And we remember there were times when I was like, none of this makes sense. How am I going to remember this? And so please remember that we're here for you. So before we get started, tell me, where in the world are you joining me from? I see Kuwait. I see India. Awesome. I saw the Philippines earlier. Canada, Toronto, Missouri. Awesome. Florida, Houston, Toronto, Mexico, Miami, New York, Georgia. I feel like I should be singing the 50 States song. This is awesome. Kentucky, Detroit, Michigan, Miami, Alberta, Kuwait. Awesome. So excited. I'm seeing Texas, Florida, seeing those on Instagram, seeing some awesome, awesome turnout. We're so excited to have you here. Very good. Okay, Dallas, Dominican Republic. All right. Philippines, Turks, Vancouver. Okay. California, St. Lucia. I bet it's beautiful there. Well, thank you guys so much for joining me all over the world. Nursing is what's bringing us together. So, before we get started, let me tell you just a little bit about myself. So, I've been a nurse for 15 years. I've done everything from stroke ICU, where you really need that cardiac information, all the way to labor and delivery, postpartum. I fell in love with that area of nursing and became a certified nurse midwife. So I practiced in an OBGYN clinic as a nurse midwife, as a nurse practitioner for about 4 years before I transitioned into education. And I absolutely love what I do. I love working with students on a daily basis, helping you to find those difficult concepts, break them down into bite-sized pieces that are retainable. Because we can feed our mind all of this information, but sometimes it's like a toddler and it says, you know what, Jennifer, you can keep making me listen to this podcast. You can keep making me listen to this webinar, but I'm totally full and I'm just not going to absorb any more of this. So my goal for us today is that we are going to absorb some of this content. So without further ado, let's get started with the cardiac anatomy. Now, this may be a silly question, but when it comes to cardiac anatomy, what's the star of the show? What's the star of the show when we are talking about the cardiac system? The heart, yeah. Does it have any backup singers, like we like to call them, or friends that are coming with it? Sing the SA node, valves. Yeah, you're right. So when it comes to the cardiovascular system, one, we're looking at the star of the show. We're looking at the heart, right? But we're also looking at those blood vessels, those arteries and veins. Yes, Jennifer, you got it. So the arteries are what are carrying oxygenated blood away from the heart. So I always think A for arteries, A away. Okay? A away. Arteries are carrying blood away from the heart. It's like, see ya, got other places to be. But we also have those veins. Now, veins are what's going to carry that deoxygenated blood towards the heart. Okay. So, arteries carry blood away, veins towards the heart. Now, I always think about of the V kind of being like a pointer. Let me show you what I mean here. So when I'm thinking about the arteries, we think A away, and I think V is pointing. Okay. So it's pointing towards the heart. It's kind of just a great way to kind of remember that information. So A away, V's towards the heart. We also have those capillaries. Now, what do capillaries do? They exchange those fluids between the blood and the interstitial space. So they're playing a vital role as well. Now, tell me about the pulmonary artery. Does the pulmonary artery follow what we just talked about? Is it carrying oxygenated blood? No, the pulmonary artery. That's right. You got it, Capri. Yes, it's carrying deoxygenated blood away from the heart. And that pulmonary vein actually carries oxygenated blood towards the heart. So that's our little caveat. That's our little stinker that's sitting out there that chooses not to follow the rules. Now, tell me what's inside the heart. Can we break the heart down into, I don't know, maybe 4 pieces? What pieces can we break the heart into? Maybe 4 chambers. Yes, Capri. Yes. We have 4 chambers of the heart. We have the atria and we have the ventricles. So I always think the ventricles looks like a V. They're at the bottom. Okay. The bottom kind of looks like a V on each side. So the atria is getting blood from the veins. The veins are bringing in blood. And then it does what? It sends blood to the ventricles. It's like an assembly line. So it's like, here, ventricles, here you go. And the right atria, or the atria and the ventricles are separated by that septum. Now, what about the ventricles? They're getting blood from the atria. That's right. So the atria are like, here, ventricles, here's some blood. And the ventricles say, thanks, atria. That's perfect. I'm going to send these out to the arteries. And there is also a septum there to separate these two. Because I like to think about, if you have siblings or you have more than one child, sometimes they need a little bit of separation. True story for the ventricles and the atria. So when we talk about blood flowing through the heart, I learned to start with the venous system, the body first. The tissues have used up all of the oxygen in the body, and now it's looking for more. So that blood really needs to be reoxygenated. Think about when you have exhausted all of your efforts, right? You need to be rejuvenated. You need to go get a little pick-me-up. Maybe go get a massage or a mani-pedi or something like that. Maybe get some ice cream. You need some rejuvenation. So the tissues have used up all the oxygen in the body and now it's looking for more. So the body needs to reoxygenate. So in order to do that, it needs to go to the lungs. But kind of like when I travel, really just about anywhere where I'm from, there are no direct flights. So the blood needs to make a stop in the heart first. Now, this is because the heart is the pump. It's the center of the circulatory system. So if the heart is bringing back that deoxygenated blood from the body to the heart, which route do you think it's taking? Do you think it's taking the veins or do you think it's taking the arteries? So the heart's bringing back deoxygenated blood from the body to the heart. Which route is it going to take? Veins or arteries? You got it. That's right. It's going to take the veins. They are responsible for blood return to the heart. The veins pertinent to the right side of the heart are the superior and inferior vena cava, the massive veins that bring blood to the right side of the heart. So it moves blood into the right atria, squeeze through that tricuspid valve on the right side and then into the right ventricle. Now, when those ventricles squeeze, it moves blood through the pulmonary valve into the pulmonary artery towards the what? So ventricle squeeze moves blood through the pulmonary valve to the pulmonary artery towards the lungs. You got it. Now, the pulmonary artery is a special kind. It's the only artery in the blood in the body that carries deoxygenated blood. But I know it's an artery because I think A is for away. Arteries carry blood away from the heart. So blood's moving from the right side of the heart headed towards the lungs so oxygen and gas exchange can happen. Remember, we need that oxygen in our blood, so it's useful for our tissue. So think about our round trip ticket. No direct flight back to the body. So we go from the lungs back to the heart, this time to the left side. So the lungs took the pulmonary vein towards the left atria, and then through the mitral or bicuspid valve to the left ventricle. And then the ventricle squeezes, moving blood through the aortic valve into the aorta towards the rest of the body. So the tissues get to use up that oxygen that's now in the blood. Okay. Now, these two sides of the heart are working at the same time, like a factory. You have people doing jobs right next to each other. The big thing to remember here is that the right side of the heart is dealing with deoxygenated blood, and the left side deals with oxygenated blood. And we have two phases. Systole is contraction, squeezing blood out of the heart. This is how that tissue gets perfused with the oxygen rich blood. Diastole is relaxation. This is just as important, but during this relaxation, the heart passively fills, and now there's blood in the ventricles to squeeze forward in systole. So it's important. We want to spend time in diastole so that we have enough blood to squeeze out in systole. Both parts equally important. We have to have both. All right. Now, what about those coronary arteries? Now, those coronary arteries are supplying the heart with oxygenated blood, right? We need that oxygenation to be able to perfuse to the rest of the body. Now, the right coronary artery is supplying the right side of the heart, and the left coronary artery is supplying the left side of the heart. And we are perfusing during diastole, during that relaxation. Now, it's really important. We need that mean arterial pressure of at least 60. That lets me know that my organs are being perfused. So if you're ever looking at a blood pressure, you're like, man, that looks really low, but the map is 65. I know that the body is getting perfused. It's getting that oxygen that it needs. Okay, so the next thing we need to talk about is action potential. Action potential. Now, somebody tell me, what is an action potential? Let me know in the chat or in the comment section if you're joining me on YouTube or Facebook. And someone asked me earlier, are we going to have slides for this? Unfortunately, we don't give out the slides for this presentation, but great news. It is recorded and it's available on our YouTube channel and our Facebook page for you to check out later. Okay. Conduction system, electrical impulse. Okay, let's see. So when we talk about the electricity of the heart, we're talking about the explosion of electrical activity, right? It's sending that message to our heart saying contract. This is the action potential or the impulse, okay? Now there are two phases in this electrical current. We have depolarization and repolarization. During depolarization, sodium is going to enter the cell. This basically kind of charges the cell, gets it stimulated. Once enough cells are stimulated, then they respond by contracting together, and that causes what? Systole. Now, after this big explosion, this big thing of electricity, the cells are exhausted. They need to rest, right? It's like they just ran this big old marathon. They need to rest. This is repolarization. When the cell membrane returns to its resting state. Now, what does this resting state do? Well, it allows the heart to experience diastole, where we are filling up again. Okay. Repolarization will always follow depolarization. Okay. Repolarization always follows depolarization. And a cool thing about the body is that the heart cells can actually create these action potentials all on its own. The heart can beat outside the body as long as it has some oxygen reserve. It doesn't need the nervous system, it doesn't need the brain in order to reproduce these electrical responses. Does anybody know where that electrical current starts, though? Anybody know where that electrical current starts? You got it. That's right. The pacemaker, that starts the electrical activity. It's the SA node. You got it. Excellent job. Okay. What if you're saying, Jennifer, I'm completely lost. I have no idea what you're talking about. I don't even know if I was taught this in nursing school, let alone ready to regurgitate this on the NCLEX exam. Let me tell you about our amazing options for tutoring. We have both private and small group tutoring. Our private tutors are absolutely amazing in all areas. They can talk with you about how to study, how to set up a study plan. Are you NCLEX ready? They can talk to you about the most difficult ways to prepare for the difficult areas of the NCLEX. This is completely tailored to you, which is really neat. So for $75, you get an hour of our tutor's time, and this is completely individualized. If you come to me and you say, Jennifer, I really am struggling with pediatrics and maternity, we can spend 30 minutes on maternity, 30 minutes on pediatrics. It's whatever you need. Now, what if you're like, I don't know what I need? Listen, we have all been there many times, probably in the same day. Totally fine. You can just say, you know what? I'm not really sure what I need. Can you help? And we absolutely can. Gurpreet says the small group studies are amazing. Yes. So our small group studies, we have these on just about all areas from NCLEX prep to test taking strategies to, let's see, pharmacology tips and tricks. We have something for everyone. We actually have a small group coming up this week with Elizabeth Diger, who is one of our amazing, well, she's currently the IP lead and she does an amazing job. But you know what? One of her very favorite things to do is to teach these small groups, especially the ones that not everyone tends to enjoy. So this Friday, Elizabeth is going to be hosting a webinar on, yep, I just lost it. Now I gotta pull this up. Hang on just a second. Okay. So this Friday, if you go to our website and check out our private tutoring options, you're going to see on the 29th that we have, actually the 28th, I apologize. Elizabeth has some small groups available talking about either prioritization or basic care and comfort. Those are her specialties, and she does such a great job with those. So make sure you scan the QR code, go check out the options available. Okay, so now I'm sure you're all here and want to know, okay, what do I do about ECGs? ECGs. Okay, who loves a good ECG? Who thinks it looks like a toddler took a marker to a page? Yes, we've all been there. So whether you love it or you hate it, let's break this down. So, what is an ECG? Well, this is synonymous with EKG, so you can hear those terms kind of used interchangeably. But this is what this means. We have this set of waves on a graph. We have a P wave, we have a QRS complex, and we have a T wave. Now, the P wave represents atrial depolarization. We just talked about that. Our QRS is our ventricle depolarization. And we know that depolarization is followed by repolarization. So that's our T wave. Now, what do we do with those? I'm glad you asked. So when we look at EKGs, you're going to see it on a grid, and this is going to really help us measure time. When we're looking at this grid, we talk about big boxes and small boxes. So in this situation, we have these little bitty small boxes, okay? And then we have bigger boxes, okay? Who remembers what does each big box represent in seconds? What does each big box represent in seconds? Yes, it does represent time. It represents 0.20 seconds. So each big box has 5 tiny boxes. So we know that if we divide that by 5, each tiny box is 0.04 seconds. Okay? So that's really important that we understand we have tiny boxes and we have big boxes. Okay? So this is how we measure time for our EKG strips. So now what about those big boxes? How many would we need of big boxes to get to 1 whole second? How many big boxes would we see in 1 second? 5, that's right. So if we take 0.20, so that's how many seconds are in a big box, and we multiply that by 5, we get 1 full second. So when we see 5 big boxes across the strip, that tells us we're looking at 1 full second that has passed. So in this strip, do we have a full second? We absolutely do. We have 5 full boxes. So it's going to be really helpful for us to be able to measure time because we want to be working with a 6-second strip. So what's the basis when we're looking at an EKG? Well, the first thing I want to know, do we have a P wave? And is there one for every QRS complex? Is that PR interval within normal limits? Is it 0.12 to 0.20 seconds? Is the QRS complex less than 0.12 seconds? Is the rate regular, or is the rate within normal limits? Is it between 60 and 100 beats per minute? And is the rhythm regular? These are things I need to ask myself when I'm looking at these strips. So let's look at this one. Is there a P wave for every QRS complex? There's one, QRS, there's one, QRS, there's one, QRS. Yes, we have a P wave for every QRS complex, but let's look down here. Here's a P, QRS, P, QRS, P, QRS, P. What happened to the QRS? So we want to make sure that we have one P wave for each QRS complex. Now, the next thing I want to know is that PR interval between 0.12 seconds to 0.20 seconds? It's going to be in between 3 to 5 little boxes. So when we look at that interval, so from the beginning of the P wave to the Q or to the end of the P wave, is that within those normal limits? Yes. But look what this, it's getting longer. It's pretty wide. Now, what about our QRS complexes? Are those within 0.12 seconds? Are they kind of narrow and peaked? And that top one, absolutely. But look at this bottom one. Where in the world are those QRSs? Those are wide. Those are bizarre. What in the world is going on? What about our rate? So remember, we want to be looking at a strip that tells us we want how many second strip? Do you remember? We want a 6-second strip. So we're going to count. What is our normal rate here? So we have, let's count them together. 1, 2, 3, 4, 5, 6, 7, 8, 9 QRS complexes. We're going to multiply 9 by 10, and that gives us 90 beats per minute. Okay? 90 beats per minute. You got it, Gurpreet. Excellent job. Now, then the last thing I want to know is the rhythm regular? Is it happening at the same time? Look at this interval. Yep, about the same, about the same, about the same. But look down here. This looks good. This looks good. Whoa, what happened? This looks good. Whoa, what happened? So in that bottom one, it's not regular. It's not occurring at in the same speed. All right, so let's look at a question together. What does the P wave on an ECG represent? Is that the ventricular repolarization? Atrial repolarization, ventricular depolarization, or atrial depolarization? What do you think? Remind me, what does the P wave tell me? What's happening? Yes. Yes, you absolutely got it. Yes, the P wave is that atrial depolarization. Okay, so let's look at some of those sinus rhythms together. We just have a few minutes left. Let's go through these together. So, normal sinus rhythm, it's good to start with normal because if I know what normal looks like, when something's out of place, something looks different, I can identify it pretty easily. So, this is normal sinus rhythm. This is normal because the heart rate is normal, it's within normal range. Everything here is normal. We have a normal upright P wave. We have a normal PR interval here. Now here on this slide, we see normal PR interval should be between 0.12 and 0.20. And what would that be in boxes if we converted it? What would that be in boxes, roundabout? It would be about 3 to 5 small boxes, okay? So we know that PR intervals measured from the beginning of the P wave to the beginning of the QRS complex. And that P wave should always match up with a QRS complex. So let's count. We have 1, 2, 3, 4 boxes. That's within our normal range, 3 to 5 small boxes. So we're good. Our QRS should be narrow. It should be sharp and pointy. Our heart rate should be within those normal limits, 60 to 100 beats per minute. Now tell me, what's our heart rate in this strip? We have, let's count our QRSs. 1, 2, 3, 4, 5, 6, 7, 8, 9. Heart rate of 90. So normal sinus needs to be regular. How do we check regularity? We're going to look at the space in between each QRS complex and make sure it's consistent every time. If it's consistent, it's regular. Now, what about sinus bradycardia? What do we notice here? There's something really important that looks very different from normal sinus rhythm. Yeah, it's a slower heart rate. Absolutely. In this case, we have a heart rate of 50 beats per minute. If the heart rate is less than 60, we have bradycardia. Everything else is the same here. The P wave matches with the QRS complex. The PR interval within normal limits. The QRS narrow, sharp, regular. So we have sinus bradycardia. Is this something we should be worried about? Not always. Sometimes this can be normal, like if someone's sleeping or maybe they're a triathlon runner. They might have a slower resting heart rate. It's just efficient and doesn't need to beat as fast. Now, we would be concerned if our client is symptomatic. They have chest pain, shortness of breath, dizziness. I'm concerned. We would most likely intervene here with something like atropine or even cardiac pacing. Now, pacing is an electrical intervention for slower rhythm. So everything in this situation here is the same, except that heart rate is less than 60. Now, sinus tach is just the opposite. We have so many QRSs here. That tells me our heart rate is high. In sinus tach, our heart rate is 100 to 150 beats per minute. Everything else is normal. Think about all the things that can increase your heart rate. Taking a big test, presenting in front of, I don't know, over 1,000 people like I am right now. There are a lot of things that can increase our heart rate, but when are we intervening here? We want to figure out the cause and we want to fix it. So if the issue is pain, what can we do? Give pain meds. If the problem is hypotension, we could give some fluids. Pretty straightforward. All right. So let's look at atrial flutter and atrial fib before we go. I want to make sure that we're able to get to some of these arrhythmias right quick. So when we're talking about atrial fibrillation and atrial flutter, when we look at these two rhythms, the first thing we notice is that the P waves do not look normal. Remember, P waves represent atrial depolarization. Now, when we see funny looking P waves, we know there is something funny going on with that depolarization of the atria. So both of these are named starting with atrial. We have narrow QRS, so the ventricles are depolarizing fine. So we know the problem is going to lie in the atria. The difference here is the appearance of the P wave. In atrial flutter, the P wave looks like a saw. So if you've ever used a saw, this is kind of what it looks like. Just those kind of of jagged little teeth, right? And they're pretty regular. These two are normally caused by some sort of heart disease, treated the same way, beta blockers, calcium channel blockers, cardioversion if they're unstable. That's that big jolt to the heart. But we're always going to use synchronized mode for cardioversion because we want to make sure that jolt is given at the right time. Now, what about atrial fibrillation? Well, we talked a little bit about it already, but I was taught to think scaredy cat. The P wave looks shaky. It's scared, okay? And that's what's happening here in the atria. The atria are shaking, they're quivering, okay? So we have those wavy P waves. Now, the last one we're going to talk about today is supraventricular tachycardia. What stands out to me here is that we have a lot of QRS complexes. So because of all of those, it tells me the heart rate is what? High or low? What do you think? High or low? What's our heart rate? It's high. Yes. The main thing we see here with SVT is the heart rate is greater than 150. We're also not seeing P waves. They're hidden. Okay. We call these PT waves. They're blended together. So we have that funny looking wave right there. Kind of see it. Looks a little funny right there before that QRS. With this being a faster rhythm, we can use cardioversion, but ideally we'd be giving some medications like adenosine, or I like to think adonosine. This is basically like a pharmacological form of cardioversion. It's going to reset the heart, cause a period of asystole. So we want to make sure we let the client and their family know. That's our main treatment here. So if there's a reason we need to act fast, like we have really low BP, our client is really unstable, we're going to cardiovert. Okay, so you're going to have to join me at another webinar in order for us to go through those heart blocks. I know a lot of you really struggle with those, and we can definitely go through those again. But remember, here at Archer Review, we are so much more than test prep. We are cheering you on. I just had a student over the weekend that sent me a message telling me that she passed, and I was absolutely delighted. Y'all, when you send us those exciting messages that tell us you've passed, I secretly do a happy dance in the middle of my office. So please, if you're struggling, don't hesitate. Reach out, send us a message at NCLEX-tutors at archerreview.com. We'll be happy to help you. If I missed your question, I'm sorry. Please send us an email. I'd be happy to answer it. But thank you guys so much for joining us. And I hope to see you back on Wednesday for our next edition of the Next Gen Nurses free webinar series. Thanks so much for joining me, guys. We'll see you next time.